Okay. So the last question that I was asked, are we okay with that so that we can move on to pneumonia?
Yes. So good morning.
Yeah, let's move on.
Hello.
Yes. Good morning.
Yes, please. I want to ask the last question.
All right. Okay.
Okay. Usually, when you walk through town, you hear people talk about asthma has a cure, asthma cannot be cured, and all that. So today we have in this lecture, I want to ask from you if it can be cured completely.
Okay.
Or is just managed as and when it comes there. Thank you.
All right. You're welcome. Okay. Yeah. So I've also heard patients saying that, okay, asthma, they come to the hospital, you give them medications, and they tell you they want to go and take some herbal medications because they've heard that asthma can be cured. What I know of is that people can grow out of asthma. You can have a child who gets asthmatic attack once a while, but then once the child grows up and gets to a certain point, you realize the child wouldn't have asthma. It goes beyond 10, 15 years, and the child hasn't had any asthmatic attack at all. Okay. It doesn't mean that the asthma has been cured. What is happening here is if the person was young and during that time the person was getting attacks it gets to a point where the person gets to know his or her trigger. Okay. So once the person is growing as an adult, he tries to stay away from the trigger factors because it's an allergy. Once you are exposed to the trigger factors, yes, you would develop an attack. So that's one part of it. And that's the reason why some people can go like 15 to 20 years without having any attack. If these people are exposed to the allergens, they would start having some form of attack. Okay, so I won't say that it can be cured. I would say that, all right, sometimes people grow out of it. Okay, and it's all partly because they get to understand their disease and they know what to stay away from and all that.
Thank you, sir.
You're welcome. All right, so you try and read a little bit more with your textbooks, and then most important thing is you should be able to make the diagnosis and manage. Okay. Next thing we'll talk about is pneumonia, and I'm sure we've all heard of pneumonia. When we're young, they'll tell you when you sleep on the floor and the cement, or when you sleep under fan, you get pneumonia and all that. They made it sound so scary. But you should say that, yeah, it was scary before the advent of antibiotics and all that. People were dying from pneumonia. Once you are talking about pneumonia, just like any inflammation, ideally we should say pneumonitis. Okay, pneumonitis, meaning there's an inflammation there somewhere. So definition of pneumonia here is you are looking at the parenchyma of the lung tissue, and you are saying the lung tissue has become inflamed. Okay. Once this lung tissue becomes inflamed, we say that, all right, okay, you've got a pneumonia. Okay. When you take the lung tissue, you realize that the lung tissue is basically developed into what we call lobes. So you'd have an upper lobe, middle lobe, and a lower lobe for the right side. The left side has only an upper and then a lower lobe. So when you've got an inflammation there, then this inflammation is restricted to just one lobe, then you can go like, okay, the person has a lobar pneumonia. Okay. And when you have an inflammation, and the inflammation is basically patchy and is scattered all over the lung, then you say, okay, this patient has a bronchopneumonia. Okay, how would we see the inflammation? Once we go down, we would know when to say that, okay, a lung is inflamed and the lung is not inflamed by the help of the X-ray. Okay, So just know that with the types of pneumonia, pneumonia can be classified based on the location. It could be a lobar pneumonia, okay, where you have a whole lobe becoming inflamed, or it could be a bronchopneumonia where you've got like a spread or patchy opacifications throughout, okay. The next way of classifying a pneumonia could be through how the pneumonia is acquired. Okay, so you have what we call community acquired pneumonia. This pneumonia, we say, as the name suggests, you get it from the community. So you get it from someone else in the community. So let's say you find yourself in a place that is overcrowded, you are exposed to somebody who has a pneumonia, we are working closely with the person coughs, you inhale the droplets, all that. It's a community acquired pneumonia. The basis here, or the main underlying feature with the name here, is that this patient coming to you has basically not been close to a hospital facility or premises within the past 48 hours. Okay. Once you get a pneumonia and then we ask you, when was the last time you went to the hospital? So I don't even fall sick. Then you know that this is not a hospital-acquired pneumonia. But then now pneumonia is a kind of pneumonia that you'll be able to diagnose if the pneumonia started about 48 hours of a patient who has been in the hospital. So when you go to the hospital 24 hours, 48 hours, third day, we realize you are coughing and all that. Then we say, all right, okay, you didn't come in with a cough. You spent 48 hours with us. You are developing some sort of cough and all that. This is a hospital-acquired pneumonia, okay? Then there's what we call aspiration pneumonia, where the content of the stomach can move and get into the airway. Ideally, in a normal person, you don't need to develop aspiration pneumonia because the stomach is actually blocked off by something we call the sphincter, the cardiac sphincter. So this prevents food from moving up into the esophagus and getting into your airway. Okay. In some conditions, however, there's a communication between the esophagus and the trachea. When we call it tracheoesophageal fistula, it's a congenital anomaly. People are born with it, so they have a communication between the esophagus and the trachea. In this case, food can move and then get into the esophagus and then get into the trachea. Okay. But with a person or a patient who doesn't have a tracheoesophageal fistula, how will the person develop aspiration pneumonia? If the person loses consciousness, the person is now unaware of whatever is happening in the system. So a patient losing consciousness, lying flat, would have food moving from the stomach into the esophagus and into the airway. A patient who is going for a surgery and is induced through a general anesthesia and the patient sleeps. If the patient sleeps, you have food moving from the stomach into the esophagus, getting way up into the airway. And that's the reason why when you're going for a surgery, we would say, don't eat before going for a surgery, because if you do eat, then once we put you down, and especially we induce a general anesthesia, you are going to have aspiration. And by the time the surgery is over, we've given you a pneumonia. Okay. There's also pneumonia in the immunocompromised, and this is the pneumonia we see in patients who have HIV, who have malnutrition and all that. They tend to get pneumonia. Most of the time, their pneumonia, the organisms that will cause the pneumonia, it's not the usual classic organisms that we know. They get pneumonia from opportunistic infection and weird organisms. Okay. So pneumonia can be caused by bacteria, it can be caused by a virus, and it can be caused by a fungi. Fungi pneumonia is more common in the immunocompromised. In a very, very active person, usually you won't get a fungi type of pneumonia. It will either be a bacterial pneumonia or a viral pneumonia, but bacterial pneumonia more common. Okay. So when you take a look at the community-acquired pneumonia, you can see the usual organisms there, the usual culprits, the staph, strep pneumoniae, strep pyogenes. Of course, Staph aureus can also cause that, Legionella, Mycoplasma, all this can cause. And you should, once you know the group of organisms this belongs to, you should be able to manage them. The strep pneumoniae, strep pyogenes, Staph aureus, Legionella, they are all gram-positives, okay? The Klebsiella, the K stands for Klebsiella. Klebsiella pneumoniae is a gram-negative organism. Mycoplasma tends to be atypical, what we call atypical organism. Okay, so when we go on, we would get to know how you manage all that. So the hospital-acquired pneumonia, as I said, the pneumonia is basically not incubating 2 days before patient gets to the hospital. Okay, usually the organisms are organisms that we tend to find more in hospital surroundings, like Pseudomonas, Staph aureus, and all that. These are organisms that will be present for other disease conditions. Like we know E. coli, Pseudomonas, Klebsiella is more common in UTI.
Yeah.
So you have a patient who's got like a UTI on the ward. You'll be managing UTIs for so many patients on the ward. Then you have a patient coming in with another disease condition. Then because you've got so many UTIs on the ward, this patient, one or the other, is exposed to the E. coli and then develops pneumonia from the E. coli. Okay, so it's more of hospital acquired. So ideally in the community, E. coli won't cause pneumonia because a patient won't cough and cough out E. coli, so it won't cause a pneumonia. But a patient will cough and cough out strep pneumonia, which is upper airway and can cause you to have a pneumonia. Okay.
Sir.
Yes, please.
I don't really get it. You say E. coli doesn't cause pneumonia?
Yes, so I'm saying that ideally in a community-acquired pneumonia, like I said, there are types of pneumonia. So community-acquired pneumonia has to do with the kind of pneumonia you get when you are out there in the community, close contacts with other people who have an infection, overcrowded places and all that.
Does it mean pneumonia is communicable? Like you can
yes
like TB, like something like TB.
Like something like
TB.
Yes. TB is a pneumonia. TB is a pneumonia. There are different types of pneumonia. Pneumonia is inflammation of the lung. TB causes inflammation of the lung. So TB is a type of pneumonia.
Oh, okay. I never knew.
Yeah, so that's the TB is a type of pneumonia. But I'm saying that the organism that will cause hospital-acquired pneumonia are not your usual organism that will cause a community-acquired pneumonia. And I was giving you an example like E. coli, which is known for causing hospital-acquired pneumonia. The reason why it causes hospital-acquired pneumonia is because it's one of the commonest causes of the usual conditions that would present to the hospital for admission, like UTIs, pyelonephritis, and all that. Okay, it's one of the common causes. So you tend to find that more in the hospital environment than in the community in terms of when you are looking at a patient who has pneumonia from strep pyogenes, strep pneumonia, because this patient is in the community and in contact with someone else who has got the infection. Okay.
Okay. What is this? What are these abbreviations? The MRSA and this?
Okay, so MRSA is methicillin-resistant Staph aureus, methicillin-sensitive Staph aureus, and vancomycin-resistant Staph aureus. So Staph aureus is a gram-positive bacteria, which ideally, as is a gram-positive, you expect that when you give a penicillin, it's supposed to kill it. But some of the Staph aureus become resistant to your antibiotics. An example is methicillin. So if you go to a hospital facility where they are using methicillin to treat a lot of infection, it gets to a point whereby the bacteria over there will develop resistance to the methicillin that is being used in the hospital facility. Okay, so when you go ahead and you use your usual methicillin or penicillin to treat that particular infection, it won't work. And this time around, you say, okay, the organism is Staph aureus, but it's not your usual Staph aureus, because when you give penicillin to your usual Staph aureus, it should work, but it's not working. It's like the Staph aureus has developed some mechanism. So that's why we say methicillin resistant Staph aureus. Okay.
Okay, sir.
And the same explanation for vancomycin resistant Staph aureus. Vancomycin is also supposed to inhibit Staph aureus growth, but when you are using it so much in a particular environment, the microorganism will develop resistance, so it won't work. Okay, so you have to use different drug. So once your lab says this is a methicillin resistant Staph aureus, a vancomycin resistant Staph aureus, it's telling you that when you go the usual route, it won't work. So use a different antibiotic.
Okay.
Okay. So the aspiration pneumonia, I've talked about it, that under normal circumstances, you won't get it, but once your consciousness is impaired, maybe alcohol, seizure, surgery, general anesthesia, and all that, then you can get it. And what is happening here is you are getting organisms from the stomach into your lungs. And the organisms that are usually found in your stomach are gram-negatives and then anaerobes. Okay. This is all important because once you have a pneumonia, you know the type of pneumonia, you know the antibiotic you are going to give. Because if it's community-acquired pneumonia, which you are expecting to have a lot of gram-positives, okay, you will not manage it the same way as an aspiration pneumonia, which you are expecting to have what gram-negatives and anaerobes. And that's the reason why you need to know the type of pneumonia. Okay, so aspiration pneumonia, you are basically getting the organisms that are found in the stomach, like gram-negatives, anaerobes. You are getting those organisms into your lungs. Okay. Pneumonia in the immunocompromised, we've talked about that. We said usually the immune system is compromised. The organisms causing this are usually those that will cause opportunistic infections, and hence would affect the individual when the immune system is compromised. So HIV infection, malnutrition, some malignancies, chemotherapy, and all that. Okay. The clinical features of pneumonia, there are 4 main clinical features of pneumonia. Okay. And as soon as a patient comes to you and says, "Doctor, I have fever, I'm coughing, I have chest pain, and I have difficulty in breathing." There's 4 things. When a patient tells you that, you should be thinking pneumonia. So fever, cough, the cough is usually productive. Okay. Fever, cough, chest pain, and difficulty in breathing. That's pneumonia. The chest pain you get is it feels like someone is stabbing you in the chest. We call it pleuritic chest pain. So surrounding the parenchyma of the lung is the pleura. And this pleura, once you have a pneumonia and it becomes inflamed, it also affects the pleura. So the pleura also becomes inflamed, which we call pleuritis. And whenever you breathe, and the lung expands and the pleura stretches, you get a sharp chest pain like someone is stabbing you. And so we say you have pleuritic chest pain. Okay. Then there's the constitutionals and there are joint pains and all that. So fever, cough, chest pain, difficulty in breathing, you're thinking pneumonia. Okay. Sometimes in the LD and the immunocompromised, they might not show the fever. So they'll just have some chest pain, cough, and difficulty in breathing. Okay, because they are not mounting an immune response to the organism, so they might not give you the classic fever. Okay. So patient has told you that now you will look out for signs, and the signs similar to respiratory distress, a little bit similar to what we saw in asthma. So you breathe fast, you use your accessory muscles to breathe. Usually you are going to have pain you are going to have pain at the side where the infection is. And once you have pain at the side where the infection is, breathing becomes a little bit difficult. So when you breathe in and out, that part where you have pain is sort of restricted during the breathing in and out phase. Okay, then there's a raised body temperature as well, usually more than 38. Your pulse will go up as well. And the BP is either normal or reduced. Okay, usually when your BP is reduced in pneumonia, we see you are getting more of a severe infection. So it's either normal or reduced. Then you're going to have signs of consolidation. And then your oxygen saturation will drop. So what are signs of consolidation? Once we say consolidation, then we want to tell you that your lung has become hard, like a wood. Okay, your lung has now become solid. Ideally, the lung is supposed to be spongy, filled with a lot of air. And on the X-ray, this is seen as black. Wherever you see air on the X-ray, it's seen as black. And wherever you see white means there's a solid structure. And that's why when you take the X-ray, you have a black background with white stripes. The white stripes are basically the ribs, okay? And then maybe the pulmonary vessels. So the black background there tells you that the lung parenchyma contains air. So when you take an X-ray and you are not seeing black and you are seeing white, then it means there's no air in the lung. That's what it means. So on the X-ray, we say this is a consolidation, or the lung has become solid because there's no air in the lung. And this will show us what? A white background. What in X-ray terms is termed as radio opaque. Okay, so if you have an X-ray and then you have radio opacity in one whole lobe, then you say this is a lobar pneumonia. If you have radio opacities spread in patches all over the lung, then you say this is a bronchopneumonia. Okay, but basically, yes, signs of consolidation, you are going to pick it up clinically, not with the X-ray. So how do we tell that there's consolidation? Ideally, when you are doing your examination, you do inspection, you do palpation, you do percussion, and then you do what? Auscultation, right? So when you take your patient who's got pneumonia, your inspection, you are going to see that restricted movement on the side of the pneumonia. If the pneumonia is on one side, you realize that the chest is moving, but one side is not really moving well. Then you know that, okay, this is where the problem is. So you pick that up on inspection, okay? Then you would want to palpate. When you are palpating the patient, you are checking the front of the chest. You are going to look out for 6 areas, okay? The back of the chest, you are going to look out for 6 areas as well. And then the side of the chest, you are going to look out for 4 areas. 6 areas here means that you are going to develop the chest into 3 different parts. So the right into 3 parts, the left into 3 parts. Okay, so in the end, you're going to have upper, middle, lower on the right, upper, middle, lower on the left. At the back, you're going to have the same upper, middle, lower on the right and left. And on the sides, you have upper and lower. Okay, so when you are examining the chest, I mean, you're going to put your stethoscope in how many different places? You're going to put your stethoscope in 6 areas in front, 6 areas at the back, making 12. Then 2 areas by the side, 2 areas by the other side, so making 16. So you are going to examine 16 areas. So this is how you do it. When you listen to the upper right, you are going to listen to upper left. The middle right, you listen to middle left. The lower right, lower left. You don't listen to upper right, middle right, lower right, and go and listen to upper left, middle left, and lower left. Whatever you pick up on the upper aspect, you are going to compare left and right. Whatever you pick up on the middle, you compare left and right. Whatever you pick up on the lower aspect, you compare left and right. You do the same thing to the back. Left, right, left, right, left, right. You do the same thing to the side. Upper right on the lateral side, upper left on the lateral side, lower right on the lateral side, lower left on the lateral side. That's how you do it when you're examining. Okay, so after your inspection, you want to palpate. So you palpate the chest in that area to look for what's compression tenderness. Usually when there's a pneumonia and you touch the parts where the pneumonia is, the patient will tell you, I have pain. Okay. So whilst you are palpating, you are looking at the patient's face for tenderness. Okay. After palpation, then you percuss. So inspection, palpation, percussion. The percussion also goes through the same upper right, upper left, middle right, but it goes through the same process. When you are dealing with a normal chest and you percuss, it's supposed to be resonant. Okay. So when you percuss your own chest, I don't know if you can hear me.
Yes, Doc.
Good. So this is resonant. So you should percuss to hear. Okay. So I'm sure you've done clinical methods, you know how to percuss. But yeah, when you percuss, this is resonant. So this is a normal sound when you percuss. Resonance means that you hear some air in there. However, you can hear this one. There's a difference. This one feels like I'm hitting a wood, right? So when you percuss, yes, when you percuss and then you hear a sound of you hitting a wood, then we say there's a consolidation. Okay, to percuss, you put your middle finger at the area you want to percuss. So if you are right-handed, you put your left middle finger, okay, basically at the area you want to percuss. It's like you spread out your whole hands at the area, but your left middle finger is on the point you want to percuss. Then you are going to use your right middle finger, okay, to hit the interphalangeal joint. Okay, so you want to hit the interphalangeal joint. You have proximal and distal. The proximal is the one closest to the nail, okay, the nail bed. So you want to hit that joint there. And once you hit that joint there, it gives you the sound. So that's percussion. So you percuss, and when you percuss and you are hearing a sound like hitting a wood, then we say this is dull. Okay. And that is the kind of sound you would hear when you are dealing with a pneumonia. When you percuss, you are going to hear what? A dull sound in pneumonia. And dull is a, yes.
Sorry for interruption.
That's fine.
I thought you said when you percuss and it sounds like a wood, like you hear some hard sounds like a wood, hitting a wood.
Yes.
It's consolidated, right? Or
it's what?
Consolidated.
Yes, it's consolidated, and consolidation means you have a pneumonia.
Okay, but right now you said you made mention of another term, and I don't get it.
Oh no, all right, okay. So I'll take it again. So when you percuss and you hear the sound like you are hitting a wood, that is your signal for consolidation, and that means that the lung has become solid. There's no air there, which is pointing to a pneumonia.
Okay.
But when you percuss and you hear a resonant sound, and so usually you have to hit normal lung for some time before you pick up the difference that, oh, this is resonance, this is dull. When you percuss and you hear a dull sound, like you are hitting a wood, the term I used was dullness. You pick a dull sound, like, yes. So you are hitting a wood. So the sound is dull, D-U-L-L. You pick up that sound. Then we say, okay, there's a consolidation. So we are dealing with the pneumonia. So that's it. The last thing,
the last are the same.
Pardon? The dull and the consolidation is the same, yes.
Okay.
When it comes to percussion and pneumonia, one other thing you should know is a complication of pneumonia can cause you to have fluid in the pleural space, what we call pleural effusion. Okay. And usually with pleural effusion, when you percuss a pleural effusion, you are going to hear a deeper form of dull, which is called stony dull. So when you hit a wall, you are hitting a wall, you see, or you are trying to hit a stone, the kind of sound you hear is called stony dull. Okay. And once you hear a stony dull sound on percussion, it means there's fluid around the lung. So it's called pleural effusion. So percussion notes 3 things. Okay. Or let me say 4 things. If you have a lot of air in the lungs and you percuss, you are going to hear what? A hyper-resonant sound. Okay, so that one is what you find when you are dealing with a pneumothorax. So I'll take it again. The normal percussion note is resonant. Okay, so that is the normal we want to hear. But at the extremes, you can have a patient who has got air in the pleural space. Okay, a condition we call what? Pneumothorax. Once you have a pneumothorax, means you have air in the pleural space. When we percuss, we are going to hear hyper resonance because you have more air in the lungs. Okay. A patient who doesn't have air in the lungs would have a dull feeling when you percuss, and that is what we say the patient has a consolidation or a pneumonia. A patient who has a consolidation or a pneumonia, which has now been complicated by fluid around the lung, what we call pleural effusion, will give you a stony dull feeling when you percuss. Are we okay? So there are 4 things. The usual resonance, hyperresonance, which you have when you have air in the pleural space, which is called a pneumothorax. And then dullness, which you feel when you percuss a chest with pneumonia. And then stony dull, which you feel when you percuss a chest with pneumonia, which has been complicated by pleural effusion. Are we good? So don't worry, when we meet in, you can put it down. When we meet in class, remind me to elaborate. Maybe we can do that clinical part of clinical method for like 10 minutes when we meet in class.
So let me elaborate and see if you are getting it. The same pneumothorax is the same as a hyper resonance. When you percuss, you hear a hyper resonance. That means the person is having a pneumothorax.
Exactly.
Yes, and consolidated and dull sound. When we percuss, meaning the person is having what is called a pneumonia.
A pneumonia, good.
That meaning the lungs have become hard.
Become hard.
The pleural effusion is the stony sound that you hear when you percuss.
Percuss. Yes, so it's called stony dullness.
Oh, okay. And that one is a complicated pneumonia.
Yes.
Okay.
So that's it. So there's
I want to clarify something. With the stony sound, or is it that you are going to feel like there's some fluid there?
No, so when you percuss and there's so the reason why you hear the stony dull sound is when you percuss and there's fluid around the lung, it's going to dampen the sound that you produce. You see, it's all about the way air moves. Okay. When you have sound waves moving in fluid, you see the fluid dulls the sound waves as compared to sound waves moving in a solid structure.
In an empty space.
Exactly. Okay. So it's all about the effects the fluid has on the sound waves. And that's why once you percuss, the fluid is going to obstruct the sound waves. And then we are going to have the fluid is going to dampen the sound waves, and you are not going to hear a classic loud sound. It's going to be stony dull because the fluid is obstructing and obscuring the sound waves. You get it?
Yes, sir. Yes, sir.
All right. Okay.
Hello, sir.
I think there was another question. Yes.
Yeah, please. In the consolidation on X-ray, you said it to be opacity.
Yes. So look white, what we call radio opaque.
Okay. So what about the pleural effusion?
The pleural effusion. All right. Okay. Yeah. So maybe I should have put X-rays in the slides, but yes. So once you have an effusion, there's going to be a certain we call it obliteration of the costophrenic angle. What I'll do is I'll take a picture a screenshot. I'll put it on your class platform when we get to the X-ray part, and then we'll discuss so that you get it. Okay.
Okay.
All right. I think it's going to drop now, so I'll just drop it and then I'll put up the last link, and then we can finish up.